This program is brought to you by Emory University.
Good morning, everybody. Welcome to Friday Fellows Conference. Our speaker this morning is Dr., as you can see on the screen, Dr. Hassan Chami. Dr. Chami is originally from Lebanon, where he went to medical school and did part of his training, and then came here to Emory, where he did his internal medicine residency. He is a first-year fellow in the clinical track. And he's going to discuss a case with us today, Dr. Chami.
Thank you, Dr. Williams. Thank you for having me. Today I will be presenting a case that I saw like on a Grady call that I found interesting, not just because of the pathology that was encountered at that time, but also how urgently our input was needed to respond to questions from our colleagues in OBGYN. To determine urgent management for a pregnant patient. So let's start with the case. So let me see. Okay, so we have a 29-year-old female with gravida 3, para 2, aborta 0. Basically, she's previously healthy, was transferred from an outside hospital after they diagnosed her with a PDA and pulmonary hypertension found on a prenatal visit. So she was 38 weeks, 4-day pregnant, and had like an uncomplicated pregnancy until the last week before the presentation, where she was like excessively tired, was inability to like walk around or do any ADLs. So she went to her prenatal visit, and she was found to be hypotensive with like a almost white pulse pressure. So they admitted her to the hospital to work that up, and they on the TTE it showed the high flow left to right shunt from the descending aorta to the pulmonary artery that was most consistent with the PDA and severe PH. So they called to try to transfer to Emory and Grady, and then eventually the OB team at Grady Hospital basically accepted the patients for like cardiac evaluation and complex delivery planning because they didn't have that at their facility over there. In terms of her like past history, she's, as I said, she's previously healthy, never had any surgeries. She had 2 uneventful pregnancies with normal vaginal deliveries in 2015 and 2016 for healthy kids. She's like no abortions or miscarriages. And as I said, she's 38 weeks and 4-day pregnant on admission. No family history of like any heart disease or other like congenital heart disease or congenital diseases. She's taking her prenatal vitamins. She doesn't have any allergies, and she used to work as in a chicken supply distribution company without any like drug exposure or smoking. She reported when asked about like as a kid if she had like recurrent like respiratory infections, and she confirmed that she had more than the usual kids. In terms of her exam, her vital signs, her blood pressure was like 130/59, no tachycardia, she was breathing okay, no hypoxia. She's 96% on room air on both upper and lower extremities. She wasn't in any distress. She was comfortable sitting in bed at 45 degrees. Obviously, because of the gravid uterus, she couldn't like lay flat without being uncomfortable. She didn't, on her cardiac exam, basically, she had a continuous harsh murmur that starts shortly after S1 and continues till after S2, associated with a palpable thrill. She had strong pulses and JVD noted up to 8 to 9 centimeter with a kind of brisk carotid pulsation on neck exam. On lung exam, she didn't have major findings. She maybe just fine crackles versus rhonchi, and her abdomen was like a pregnant, couldn't feel the liver or any other distension. She had a trace of +1 lower limb edema, good pounding pulses, and she had no neurologic deficits. So her basic labs was pretty unremarkable except for BMP of 1522. This is at Grady, and her BMP back in the other hospital like a few days ago were like in the 4,000s. Her EKG basically mostly unremarkable except for possible LVH with like maybe pseudo delta waves, and like no evidence of other like arrhythmia or abnormality that we could find at that time. Chest X-ray was notable for cardiomegaly, some increase in lung markings, but no like signs of infection or like pericardial effusion. Just the cardiomegaly was a remarkable feature. So basically, going into after that case, we're gonna go over the objectives of the presentation. So I will be describing brief or like recalling the fetal circulation and the ductus arteriosus anatomy, and we will be able to identify some of the epidemiologic features of PDA and explain the physiology and the subsequent clinical manifestations, evaluate patients with PDA, and then moving to pregnancy-related issues, which we're going to go over the various cardiovascular changes during pregnancy and able to assess like maternal risk in pregnant patients with cardiac conditions, more focusing on pulmonary hypertension in these patients, and to kind of briefly examine management of congenital heart disease associated PAH. So in terms of going back to embryology and anatomy, so the fetal circulation basically has three major shunts where the blood usually goes from the umbilical vein to the liver, and instead of like wasting all this oxygenated blood in the liver, we have the first shunt, which is the ductus venosus, which connects the umbilical vein to the IVC, so that it kind of mixes the deoxygenated blood with the oxygenated blood and goes to the right atrium. And from the right atrium, a lot of this blood will go through the patent foramen ovale and to go to the left side of the heart, also to kind of get the oxygenated blood to the systemic circulation. And almost 60% or 2/3 of this blood will go into the to the RV, and since the lungs are fluid filled, so basically the blood will have to be shunted to the systemic circulation through the ductus arteriosus, which connects the PA artery, the PA with the descending aorta. Focusing more on the ductus arteriosus, basically, it is basically a vascular connection between the PA and the aorta, and usually it is at the junction of the main left PA junction to the DA distal, to the descending aorta distal to the left subclavian artery. And histologically, it is different than the tissue of the aorta and the PA, and it has like more thicker intima, more smooth muscle fibers that are arranged in a more spiral fashion, which can help us understand like the how it closes later on. And usually in the fetal circulation, the diameter of the ductus arteriosus is usually close to the descending aorta diameter. In the fetal circulation itself, as I said, the RV accommodates almost 60% of the cardiac output, and due to the high pulmonary vascular resistance, and at the same time where the placenta is creating a very low resistance vascular bed, this will result in a low systemic vascular resistance, and eventually the majority of the blood will be shunted from right to left. This will allow the oxygenated blood go to systemic circulation and supply the fetus. But what about after delivery? So what happens after delivery, basically, the respiration and the lung expansion will induce pulmonary vasodilation and drop in the pulmonary vascular resistance, as well as increase in the arterial oxygen tension, along with placenta removal, and this will lead to rise in the systemic vascular resistance and also drop in the prostaglandin and prostacyclin levels. This will result eventually into a sudden shunt reversal from right to left to left to right. So all these changes that happen immediately after delivery will result in constriction of the ductus arteriosus that will start, and there will be almost functional hemodynamic closure within 10 to 15 hours, and basically complete closure at 2-3 weeks of age. Sometimes complete closure would happen at like 24 to 48 hours usually. So that's in the normal situation. What about in the patency of the ductus arteriosus basically happen mostly in conditions that are related to low arterial oxygen content and circulating prostaglandins and prostacyclin, which are the two main determinant factors of PDA closure, of DA closure. So like, for example, conditions that are associated with like poor lung expansion, respiratory distress, aspiration, prematurity, all these features are related, will cause low oxygen content and will delay removal of the prostaglandin and prostacyclins from the circulation, and this will prevent PDA closure. A lot of times also, it's not an isolated PDA. There's also associated congenital heart diseases that also cause hypoxia and cyanosis. And in these patients, PDA is essential for survival, and it is good that it doesn't close, and we try to prevent closure in these patients. So the incidence is basically variable, and the definition of when it's abnormal is also variable, because especially in the situations where other congenital heart diseases are present. But overall, it's usually considered abnormal if it like persisted after 3 months of age. The incidence ranges between like 1 in 2,000 birth, which represents like 5 to 10% of all congenital heart disease patients, but can be as high as 1 in 500 if we include like patients who are detected later, incidentally, or silent PDAs, like our patient. There's a female predominance 2 to 1. And one of the most important risk factors is prematurity. Other classical risk factors include congenital rubella syndrome, high altitude, which also affects oxygen tension. And we noticed that there are some genetic factors probably exist because like it's seen more in siblings, and it's associated with other genetic syndromes that has other like congenital abnormalities as well. So in terms of PDA pathophysiology, so the hemodynamic effects of the disease or of the shunt is basically determined by the magnitude of shunting. And not just that, also the ductal configuration and the resistance in the shunt itself, as well as the pressure gradients between the aorta and the pulmonary artery, basically can affect what are the hemodynamic changes. So overall in PDA, it's like with every left-right shunt physiology, there will be like pulmonary overcirculation and LV volume overload. So where in the pulmonary circulation will be increase in the fluid volume, decrease in the lung compliance, and at some point increase work of breathing. In terms of LV volume overload, there will be eventually increase in the left atrial and left ventricular and diastolic pressures, and the ventricle will try to compensate by increasing the stroke volume, and eventually this will result in LVH, kind of trying to normalize the wall stress. At that point, also there will be like neuroendocrine activation, increased catecholamine levels, resulting in increased contractility, increasing heart rate, and this will eventually result in increased myocardial tension and oxygen demand. Along with that, there will be some sort of diastolic steal, which is basically the diastolic runoff of the blood from the descending aorta back to the PDA. And when they are also tachycardic, there will be short diastolic time. So this will result in low diastolic pressure, which we can see in these patients as the white pulse pressure and bounding pulses. Eventually, all these changes will lead at some point into subendocardial ischemia, and the longer the duration with this shunting, there will be eventually increase in pulmonary vascular resistance to the extent it will exceed systemic pressures and will lead into shunt reversal and Eisenmenger syndrome. Speaking about configuration of the ductus, they did like angiographically, they found like many multiple types of these lesions that could be conical, could be short with narrowing at the insertion, could be tubular, and could be sometimes bizarre configuration. All these features determine the degree of shunting and also affects how to close these shunts later on when transcatheter procedures are planned. So in terms of clinical manifestations, it is It is usually variable because depending on the hemodynamic changes and the degree of the shunting, and it could range from being asymptomatic, incidentally discovered, small PDA, to patients coming in with a severe congestive heart failure and pulmonary hypertension, signs of fluid overload, shortness of breath, orthopnea, PND, abdominal distension, lower limb edema, the classical signs and symptoms of fluid overload and heart failure. Some patients would just report exercise intolerance before the diagnosis, and so a lot of patients will be kind of misdiagnosed as reactive airway disease. Sometimes the arrhythmias would be the first manifestations, such as atrial fibrillation, owing to the left atrial dilatation and increased left atrial pressures. In terms of physical exam, the hallmark finding is the PDA murmur, which is a continuous machinery murmur, mostly heard over the left upper sternal border, and can radiate to the back and sometimes to the left side of the sternum, and usually associated with the thrill. There are other murmurs could be present, sometimes hard to kind of appreciate them with that machinery murmur in place, which are the pulmonary regurg murmur, tricuspid regurg murmurs, obviously the exam will be, it depends how fluid overloaded the patient, but usually crackles are uncommon in these patients. Bounding pulses and white pulse pressure is also a sign, which is not specific to PDA, but it's usually there. One kind of classic teaching sign is cyanosis and differential cyanosis, which is especially seen in like hot weather or after exercise when the systemic vascular resistance drops and there will be some sort of right to left shunting, and oxygenated blood will go to the upper part of the body above the left subclavian artery, and less oxygenated blood will go down to the descending aorta, causing cyanosis. And with long-term pulmonary hypertension and hypoxia, there will be eventually clogging. Other like usually the normal tests we do, chest x-rays and EKG. Again, there's a lot of features, could be normal, ranging to cardiomegaly, increased markings, sometimes large main PA, and in adults, sometimes we see ductus calcifications. ECG usually mostly normal, sometimes sinus stack, AFib, and signs of any of these hemodynamic effects like atrial enlargement, RVH or LVH. And moving forward to echo, which is basically the diagnostic study of choice in these patients, and it helps confirm the diagnosis, provide hemodynamic assessment of the shunt, and the best views for evaluating PDA are usually the hypersternal short axis and the suprasternal views. Important tool, it's important to use it for also to categorize the pulmonary to systemic flow ratio, where we can calculate the QP-QS ratio and identify whether the shunt is a small, moderate, or large, depending on that, where small shunts have like QP-QS less than 1.5, moderate is between 1.5 and 2.2, and large is above more than 2.2. So moving forward to our patient and her echo, I got some of the images that we saw to just have an overview of what her echo looked like. So when the OB team called us to kind of evaluate this patient, it was like around 7 p.m. The main question was like whether this patient has really severe pulmonary hypertension on echo, because that will change their delivery plan, and to see how they're going to manage her basically delivery, anesthesia. Is it going to be normal delivery, normal vaginal versus C-section? So we had kind of to respond more on the urgent side and like to go into the hospital, get the echo tech to get a good images for the PDA and assess the PA pressures. And we were able to do that. It was on a Sunday. So that was a good management at that time. So in terms of her plaques view, as you can see, there's like huge dilated LV, and dimension was like LVIDD was 7.9 centimeter, with relatively okay EF on this view. I didn't include all the EF views like the short axis or the subcostal views. But overall, the EF wasn't like reduced. In terms of other views on her echo, we had the apical four-chamber showing the tricuspid valve, and as you can see, she had a significant tricuspid regurg with Vmax of 372. Her estimated RVSP was around like 58 to 63, signifying moderate to severe pulmonary hypertension. And most importantly, the PDA views, as I said, we usually tend to look at them mostly on the parasternal short axis and the suprasternal views. On this view, I'm showing here the so on this side of the slide, I have the landmarks of what we're looking at. This is the short axis view at the aortic valve, showing the RVOT, the main pulmonary arteries, then the right PA, left PA, and the descending aorta where the PDA usually is located. And this is like an animated view. I hope you are able to see it clearly. And on our patient echo, this is her Doppler view. And as you can see, there is like the flow through the RVOT to the main pulmonary artery. Then there's like a continuous flow coming back from the side of the descending aorta down to the left pulmonary artery. It will be more obvious on the suprasternal notch, suprasternal view. So, and moving forward to that view where we're looking at the suprasternal view, showing also the landmarks. Again, we have the aorta, the right pulmonary artery, and this is the descending thoracic aorta. And usually the PDA is usually located between the descending aorta and the main pulmonary artery or left PA. So we can see in this video the continuous shunt there's there. Are the images clear?
Yeah. Okay. Can you go back one image real quick, Hassan? Sorry to mess up your, a quick editorial comment. This is a favorite image on the cardiology boards and the echo boards as well. They love showing this image of this sort of, even an image like this, sort of a grainy picture of what's probably a PDA. So just sort of burn this from this short axis view. They love showing that on board exams.
And it's Dr. Thaler, this is like a really nice, easy example. Most PDAs is not going to be this. Like it's going to be really subtle and it could be super, super easy to miss on an echocardiogram. But at least what you'll be tested on is something that'll be obvious like this.
Okay. So again, the suprasternal notch, and just like, and you can see it here, the continuous flow going to the PA. So other so now we on the echo we can obviously saw the shunt and that is continuous. One other also important feature is to assess the hemodynamic effect of the shunt, and this is by calculating the QP and the QS. So to do that, what we did is like we basically got the LVOT diameter and the LVOT VTI and compared these to the RVOT diameter and the RVOT VTI. Unfortunately, we did not have a PW for the RVOT, so we used the continuous wave to calculate the VTI and kind of make our calculations. So basically, the formula is pretty straightforward. QP is RVOT VTI times pi times RVOT diameter over 2 squared, and same thing for the LVOT, and then we do the ratio. So based on these numbers that we had, the QP to QS ratio was 2.552, which signify a large shunt, and that would kind of goes in line with all these hemodynamic changes of like significantly dilated LV, dilated LA, and other like regurg, valvular regurg, and elevated RVSP. One other
Dr.
thing,
Thaler, again. So you absolutely should know how to do this QP to QS measurement because it's also a favorite test question if you take your echo boards, is they'll give you, and they'll just make the numbers easy from a math standpoint. in real life, looking at this echo, it's a large shunt. And so even if it's not a large shunt, we can talk about management at the end. In real life, we don't necessarily go based off of the echo shunt. As much as I love echo, there's a lot of pieces that make it, as you're showing, difficult to truly accurately estimate it.
Thank you. One and also other kind of echo findings that we look at is basically diastolic flow reversal and the descending aorta. As you can see in this picture, like in the PW at the descending aorta, showing like forward flow, and then they're like continuous flow in diastole, which is kind of responsible for the diastolic runoff and diastolic steal that I mentioned before, resulting in drop in the diastolic pressure and wide pulse pressure. And same thing in the RVOT, showing like continuous flow at that point. So basically all these kind of tell me that this patient has a large shunt with a continuous flow, mostly left to right shunting. And this will be kind of and associated obviously with moderate to severe pulmonary hypertension. So basically what we had to get the echo, as I said, urgently, and we spent like a lot of time waiting to get pushed, and then we read it almost at 11 p.m. To get like all the answers they need for planning for delivery. As we said, the report was like large patent DA with continuous left to right shunt. She had EF of like 45 to 50%, flattened septum signs of consistent with RV volume overload, and severely dilated LA. RVSP 58 to 63. Luckily, her RV function, I didn't show it in the images, but it wasn't significantly affected, which may be why she had at least a more favorable outcome so far. These are the main kind of echo findings that we saw. So after that evaluation of the PDA, it is important for when we're giving our recommendation also to understand how like congenital heart disease or in general cardiac conditions are affected by pregnancy, and what are the kind of hemodynamic changes that occur in pregnancy to give better recommendations. So basically, in terms of these changes, most everything basically kind of increased during pregnancy, including plasma volume, stroke volume, heart rate, and cardiac output, where like blood volume usually increases almost by 40% by week 32, and cardiac output usually like 30 to 50%, and is also affected by body posturing due to the pressure on the aorta or the vena cava from the gravid uterus. Pulmonary vascular resistance usually decreases by almost 24%, and this can accommodate the kind of almost 40 to 50% increase in the pulmonary flow. So the PA pressure usually does not change during normal pregnancy. One important feature, as we said earlier, with the placenta, owing to like a low resistant vascular bed, systemic vascular resistance drop in these patients, and then to go up later on after delivery. In terms of cardiac structure, some changes would happen to the heart owing to these hemodynamic changes, and specifically like there will be some dilation in the aortic root or ascending aorta, which are usually not significant, but could be significant in patients with aortopathy, and we have to be careful in these patients. LA diameter would increase by almost 0.4 centimeter. LVEDD would increase. LV mass also could increase, especially if they're hypertensive as well. It will significantly go up. And sometimes effusions can develop, affecting also the hemodynamics and the loading and unloading conditions. Overall, the EF should not change, and the pulmonary arterial pressure should not change, and RVEF should not change, because the changes in the heart should accommodate the hemodynamic changes. So it is also not just during pregnancy, labor also has a lot of changes that could impact our management plan, where during active labor, there will be increased heart rate, CVP, cardiac output. Also with each like contraction, the uterus will expel almost up to 400 milliliter of blood into the venous circulation, as if you're giving fluid boluses, resulting in increased CVP, RA pressure, cardiac output and blood pressure. And the cardiac output could go up to 50% by the second stage of labor. And again, maternal position can modulate these hemodynamic response due to vena cava obstruction or aortic pressure on the aorta. It is important to kind of maintain adequate pain control to kind of prevent the rise in the arterial pressure and the increase in the systemic vascular resistance. And to be careful with like what type of anesthesia we should use, where epidural anesthesia, for example, can induce like venodilation, reduces venous return, and can cause bad effects in patients who are preload dependent. And usually we try to avoid like bolus dosing of anesthesia, and we use like incremental, mild, smaller doses to adequately control pain without having the like negative effects on the preload. Also, Valsalva during the fetal descent and the pushing can also reduce the venous return and cardiac output. And a lot of times assisted delivery is helpful to kind of minimize that fetal descent and make it faster process to get the baby out and avoid the changes. After delivery, basically the cardiac reserve is again challenged by the compression of the IVC and basically autotransfusion of the contracted uterus. And there will be increase in the preload, increased cardiac output again, and following vaginal delivery. So patients who have like their borderline and tenuous cardiac function, that increase might not be accommodated easily, and postpartum complications could happen. And after delivery, if everything is good, usually the pre-labor cardiac output returns within 1 hour to 24 weeks. Usually mean arterial pressure increases for like 1 to 2 days, then decline over the next 2 weeks. PVR increases to preconception levels within 6 months, and maternal blood loss, whether like with normal vaginal delivery or C-section, owing to like almost 0.6 to 1 liter, can cause tachycardia and increased stroke volume in these patients. So knowing these hemodynamic changes and knowing like our cardiac underlying cardiac condition, usually we are tend to ask like what's the maternal risk for these patients to get pregnant in the first place or to continue with the pregnancy, and how to manage pregnancy throughout. So, and we a lot of times we're asked to see these patients, for example, in Midtown, but usually these patients are hooked up with the adult congenital heart disease clinic, and they have like a known plan ahead of time, what to do and how to manage their pregnancy. And over the past like several decades, there have been several risk stratification scores that have been developed to kind of assess the maternal risk during pregnancy. And the most reliable tool available is the modified WHO score or classification. Basically, where it classifies patients into class 1 to 4. I mentioned class 3 and 4 because these are the most important ones, but where like class 1 and 2 usually include patients with like more simple lesions and less advanced cardiac risk factors. And it's associated with like no to moderate maternal morbidity and mortality. Class 3 has like more significantly increased maternal morbidity and mortality. And usually these patients need expert counseling. They will need intensive specialists, cardiac OB, and like MFM, ICU monitoring, and more kind of frequent visits, and so on. Class 4 patients usually are significantly or extremely high maternal morbidity and mortality, and usually in these patients we recommend against pregnancy. And in the setting of pregnancy, like termination of the pregnancy needs to be discussed. A lot of times the patient wish to continue with the pregnancy. In these situations, we manage them as class 3 patients. There's no like a specific guidelines on how to manage them in a different way. So our patient basically has pulmonary hypertension. So she's assigned to the modified WHO class 4.
I actually think she has probably, because I've looked at her case, she just hasn't followed up with us due to insurance issues. I think she has significant shunt, and so she's probably class 3 and isn't truly Eisenmenger's. And the challenge is these patients, if you see that like massive flow, from the PDA, from the echo, it's really hard to determine, do they truly have pulmonary arterial hypertension? So really the only way that we'll actually know if she has pulmonary arterial hypertension is to do an invasive cath for her. But she probably is still not crossed over, or if she does, she probably has very low pulmonary arterial hypertension based on her echo. Regardless, you would manage her, like you said, like class 3 or class 4. But that can be one of the most challenging things, is that people will get told based on some of the stuff that there are class 4 when they're not necessarily. And the other issue with pulmonary hypertension is often you have to make sure it's pulmonary arterial hypertension, because I'll often, and I've seen more than one patient where they've actually had their tubes tied or something that's permanent sterilization because they were told they were class 4, and they don't have pulmonary arterial hypertension. They might have obstructive sleep apnea leading to elevated PA pressures, or left atrial hypertension, all of which is not truly a contraindication to pregnancy. And so that's the other thing that has to be carefully discussed, and make sure that you have your diagnosis before you tell someone to do something that's permanent.
Yes, yes. Yeah, totally agree. So moving forward from that, as we said, the pulmonary hypertension in pregnancy, basically, it is one of the least well-tolerated conditions and associated with high maternal mortality, in some reports 25 to 56%. And again, as we said, if we're accurately diagnosing it as a PAH and assigning it to modified WHO class 4, pregnancy is usually contraindicated and termination needs to be discussed. But again, we have to be also accurate in our diagnostic evaluation. Congenital heart disease associated PAH is the most common pathogenesis, usually representing around 65% of cases. And it was found that it might have better outcomes compared to idiopathic PAH. Also grouping all these patients under PAH into the high-risk group and modified WHO class 4 might be not 100%. And it could be less severe PH may have more favorable outcomes compared to more severe PH. And this, this hypothesis was also studied relatively recently, where they kind of published a study last year on pulmonary hypertension, pregnancy-associated pulmonary hypertension. And they studied basically almost 2,200 patients, out of which almost 730 patients had CHD PAH, where 65% of these patients had systemic to pulmonary shunting. And they found that patients with moderate to severe PAH had worse outcomes in terms of mortality, heart failure, decline in the NYHA class, maternal complications and fetal complications, compared to patients with mild PAH. So it's assigning risk to these patients also should be more counseling needs to be done, and it could be more nuanced versus just completely contraindicated and tell the patient you should not get pregnant. And in pregnancy specifically, the important feature with the pulmonary hypertension is this long-term left to right shunting and subsequent shunt reversal and Eisenmenger syndrome. And usually the greatest risk of death is usually in the postpartum period, but it also may extend to beyond 6 weeks after delivery. Usually the outcomes are poor, related to hemodynamic changes in pregnancy, and the prognosis is driven largely by the RV function. In patients with PAH, when the changes, the hemodynamic changes can be affected in terms of there will be no fall in the pulmonary vascular resistance. There will be more drop in the systemic vascular resistance, worsening the right to left shunting. The RV and the heart will fail to augment the increase in the plasma volume and cardiac output. And in labor, there will be more abrupt hemodynamic changes, and also there will be increase in the prothrombotic state and maybe pulmonary thrombosis, like in situ pulmonary circulation thrombosis, increasing the pulmonary arterial pressure.
And I think your last slide, that is like probably one of the biggest take home points is the risk of death in terms of the period is often the postpartum period. But we actually are monitoring the patient in that, but it's really that 6 weeks after delivery. And so a lot of these patients will end up being taken care of by general cardiology because there's a lot of places that don't have referral centers or there's not availability like for this patient. And so that 6 weeks post delivery is just a really critical time period. And there's an increasing literature saying that's really the time period. Like we're doing great getting these women through pregnancy, and then they don't follow up with OB until 6 weeks postpartum. And there's this gap in care, and that's where all the bad outcomes are probably currently being a good portion being driven from. And so when you're seeing these patients coming up with one, good counseling, but also a better options in terms of how are you going to follow them during that period to help make sure that they don't get into trouble.
The complications of in these patients, usually maternal death, happen mostly due to RV failure, arrhythmias, and hemorrhage. Sometimes like worsening cyanosis and tissue hypoxia. Also, it's not only on the maternal risk. Also, the fetus would have like increased risk of fetal death, preterm delivery, intrauterine growth retardation. So we have to keep that in mind as well. In terms of management, so obviously these patients need to be managed in a tertiary care center with like expertise, not just in MFM, adult congenital critical care, but also like cardiac anesthesia, NICU. So a lot of like all these people need to be involved to have better outcomes. Again, pregnancy termination needs to be discussed early on, which is not relevant to our patient because she was late. But still, even that is still a higher risk after 12 weeks of pregnancy. They usually should have more frequent visits, sometimes more like frequent echo or like testing to have better evaluation on their hemodynamics. And in patients who need like who has already proven PH, knowing like the treatments for these patients and what we can use in pregnancy is also important, where like pulmonary vasodilators like PDE5 inhibitors, prostacyclin analogs can be used, whereas like endothelin receptor antagonists are teratogenic and should be prohibited. Again, also cautious use of diuretics because some of these patients are preload dependent state, so you want to avoid also volume depletion. And a lot of times we think that we're going to be asked about like how they should deliver the patient. Usually, I don't think we answer that question specifically. We more assess the risk, and they, based on that, they will go by the clinical status of the mother and the fetal maturity. And usually it ranges between like induction of labor, assisted vaginal versus C-section, with careful use of anesthesia, as I previously mentioned. And inhaled nitric oxide can be helpful also in these patients. And obviously ICU care postpartum is important, as we said, because of this is the probably highest risk period where changes can be really associated with negative outcomes. And it's going to also we should consider therapeutic anticoagulation with like unfractionated heparin to prevent venous thromboembolism in these patients. But obviously there should be no concerns for bleeding because that also will be a major issue. Usually these patients have a delayed hospital discharge just to watch them a little bit longer than usual, and they should have a close follow-up after the delivery, and to make sure we're not having any deleterious effect on the heart following in the postpartum period. So back to our patient. So what happened, basically, she was like having contractions overnight, and they had kind of to be more fast in terms of getting her delivered. She didn't tolerate induction due to some deceleration, so they went into an emergency section. Luckily, she had a healthy 2480-gram baby, and she did not have any like immediate postpartum complications. She was monitored in the ICU afterwards, and she was given contraception, which is also an important part of the counseling for these patients. And then she discharged home on day 7 after admission. She was supposed to follow up in the adult congenital clinic with Dr. Harden, but Last time I checked, I didn't see that I think she missed her appointment and they left messages. And I don't know what will happen moving forward. I saw that she was recently seen in an emergency room, but it was more for like a bleeding, vaginal bleeding. So it wasn't like a decompensated heart failure thing or anything like that. So in conclusion, basically, PDA, basically, we don't see it that much, but it accounts to 5 to 10% of all congenital heart disease, and can be identified incidentally later in adulthood. And physiology involves LV fluid overload, eventually shunt reversal and Eisenmenger syndrome, depending on the degree of the shunting. Echocardiography is modality of choice to evaluate PDA, although other imaging modalities could be helpful, like cardiac MRI, multimodality imaging, and CT. Presence of PDA and congenital heart disease associated PAH are associated with worse maternal fetal outcomes during pregnancy due to various hemodynamic changes. RV function and severity of the PAH are a main determinant of outcomes, and management of these patients basically need a multidisciplinary team of experts in mostly all the fields involved. Just one acknowledgement, like thanks to Dr. Honora, who really helped me kind of go over the echo for this patient and kind of make the calculations and like going over all these changes and she was on call with me that day when we admitted the patient, and we spent like the night discussing how we need to address this situation. Also thanks to Dr. Thames, we also kind of reviewed the case with him at that time, and we run over the echo and everything. So thanks to Dr. Honora and Dr. Thames for helping me out. These are my references and questions and thoughts.
Really nice presentation, and very thorough in terms of everything that you went through. So thank you so much for presenting this. A couple other things that are interesting about PDAs in terms of closure. So the guidelines would say if it's a greater than 1.5 to 1 shunt, but the reality is that most people are more aggressive than that in terms of closing these PDAs in adulthood. So often if you can hear the murmur, most people will just close it, even if you don't have, just because it's fairly low risk, especially if it's easy to close. The things to think about post-closure that can happen is it should be good in that it's just you're coiling in the PDA. But depending on the way it's closed, and it's more an issue in infants when it's closed percutaneous, is you can actually get a reverse coarctation. So if it goes into the aorta where your closure device is, you can have decreased blood flow to the head and neck vessels, which again is a rare complication, but definitely something to think about if people are having like upper extremity symptoms after closure. And then the older the patient, the harder it is to close it because it's calcified. So it gets harder to surgically close it, but it's also harder from the interventionalist. So the older the patient, the harder you have to think about whether or not they're going to tolerate the closure of the PDA. So it's definitely something that we see. A lot of it is taken care of in pediatrics, but a few will make it through. And then we have a larger population here in Atlanta just because we have a large immigrant population here, which is where we see a lot of our patients through.
All right.
Hassan?
Well, yeah, thanks, Hassan. Good review. Any other, and thanks, Dr. Thaler, for your input and expertise. Any other thoughts, questions from the audience for Hassan?
Hassan, this is Ifoma Honora. I just wanted to say wonderful talk and a great review of something we don't see often as a general cardiologist.
Thank you.
Well, the European guidelines also have a really great review of management of pregnancy. I think it's from 2018. And I encourage everyone to look at it before your general cardiology boards, because at least the year I took it, I mean, it seemed like, a quarter of the patients were pregnant. And a lot of that is driven from that guideline that I think a lot of the questions were coming from.
Stan Sherman, if she had come back for follow-up, I take it she'd be sent for closure.
Yes, I think as long as, I mean, she needs a cath to make sure that her PVR is low. But I suspect it'll be low enough that should be able to close it. We just need to get her in and then get her a cath, and then she should be able to be hopefully closed percutaneously.
All right, well, thanks again to Hassan. Thanks for everybody for tuning in today, and we'll see everybody next week.
The preceding program is copyrighted by Emory University.